Hello and welcome. Today we're diving into a condition that can significantly impact vision, anterior ischemic optic neuropathy, often called AION. At its core, arises from a lack of sufficient blood flow to the optic nerve, specifically to the anterior portion, where the nerve exits the eye. This blood supply disruption can stem from a variety of factors. Non-arteritic AION, the more common form, is frequently linked to underlying vascular risk factors like high blood pressure, diabetes, high cholesterol, and sleep apnea. Arteritic IO, on the other hand, is caused by inflammation of the arteries supplying the optic nerve, most commonly due to giant cell arteritis, a serious autoimmune condition affecting older adults. Let's delve into the pathophysiology. When the blood supply to the anterior optic nerve is compromised, the nerve fibers suffer from oxygen deprivation, known as ischemia. This ischemia leads to swelling of the optic nerve head, the visible portion of the nerve at the back of the eye. The swelling further compresses the already vulnerable nerve fibers, resulting in damage and cell death. This damage disrupts the transmission of visual information from the retina to the brain, causing visual impairment. AIO predominantly affects individuals over the age of 50, with non-arteritic AION being the more prevalent type, affecting people in their 50s, 60s, and 70s. Arteritic AION linked to giant cell arteritis typically affects older adults, usually those over 70. Certain predisposing factors, such as a crowded optic disc, characterized by a small cup-to-disc ratio, appear to increase the risk of developing non-arteritic AION. Those with pre-existing vascular conditions are also at higher risk. The hallmark symptom of AION is a sudden, painless loss of vision in one eye. The vision loss is often altitudinal, meaning it affects either the upper or lower half of the visual field. Some individuals may also experience blurred or dim vision. In cases of arteritic AION, additional symptoms related to giant cell arteritis may be present, including headache, scalp tenderness, jaw claudication of pain while chewing, and general fatigue. Diagnosing AION requires a comprehensive eye examination. The doctor will assess visual acuity, visual fields, and color vision. A dilated fundus examination allows direct visualization of the optic nerve head, revealing characteristic swelling. Blood tests, specifically erythrocyte sedimentation rate ESR and C-reactive protein CRP levels, are crucial in suspected cases of arteritic AION to assess inflammation. If giant cell arteritis is suspected, a temporal artery biopsy may be necessary to confirm the diagnosis. Optical coherence tomography, or OCT, can be used to measure the thickness of the retinal nerve fiber layer and monitor for progression. AIO is generally divided into two main categories: non-arteritic AION and arteritic AION. Non-arteritic AION is the more common type and is associated with vascular risk factors. Arteritic AION, as we discussed, is caused by inflammation from giant cell arteritis. There are other rare forms, but these two encompass the vast majority of cases. The treatment and management of IO differ depending on the underlying cause. For non-arteritic AION, the focus is on managing vascular risk factors to prevent further damage and reduce the risk of affecting the other eye. This includes controlling blood pressure, blood sugar, and cholesterol levels. There is no proven effective treatment to restore vision lost due to non-arteritic AION. For arteritic AION, prompt treatment with high-dose corticosteroids is critical to suppress the inflammation and prevent further vision loss. Early diagnosis and treatment are essential to minimize permanent damage. While there is no guaranteed way to prevent AIN, especially non-arteritic AO, managing vascular risk factors is paramount. This includes maintaining a healthy weight, eating a balanced diet, exercising regularly, and avoiding smoking. Regular eye exams are also crucial for early detection and monitoring of the optic nerve. In the case of arteritic AION, being aware of the symptoms of giant cell arteritis and seeking prompt medical attention can help prevent vision loss. The prognosis for AION varies. In non-arteritic AION, vision may stabilize or improve slightly in some cases, but significant recovery is uncommon. There is a risk of the other eye being affected in the future. In arteritic AION, with prompt and effective treatment, further vision loss can often be prevented. Recent research is exploring potential neuroprotective agents that may help protect the optic nerve from damage and promote recovery. Studies are also investigating the role of various biomarkers in predicting the risk and progression of AION. While there are still many unknowns, ongoing research offers hope for improved treatments and prevention strategies in the future.